Hello. Anesthesiologists who perform pediatric cardiac anesthesia or are interested in pediatric cardiac anesthesia, welcome. Bonjour, bienvenue aux anesthésiologistes pratiquant l'anesthésie cardiaque pédiatrique ou intéressés par celle-ci. Buongiorno, benvenuti a anestesisti che eseguono anestesia cardiaca pediatrica o che sono interessati all'anestesia cardiaca pediatrica. Today, we're taking a deep dive into one of the most fascinating and urgent challenges in our field, dextrotransposition of the great arteries, or DTGA. It's a condition that presents us with a profound physiological puzzle right from the moment of birth, and our ability to solve that puzzle is really a beautiful story of decades of medical and surgical innovation.
So, here's our game plan. We're going to start with the absolute core of the problem, the paradox of those parallel circuits. Then we'll get into the nitty-gritty of diagnosis and the different clinical flavors of DTGA. After that, we'll talk about the critical bridge to surgery, all the things we do to get these little ones stable. Then, for the main event, the art of the switch, where we'll break down the surgical fixes. We'll follow that with post-op management, and finally, we'll put it all together with a real-world case study. Sound good? Let's jump in.
Okay, so at the very heart of DTGA is this massive anatomical mistake. Think of it like this. Instead of a single continuous racetrack for the blood to follow, the body has built two separate highways that run side by side but never, ever intersect. And understanding this paradox, this fundamental flaw, is the key to everything else we're going to talk about today.
So let's get the official definition on the table. DTGA is a state of ventriculo-arterial discordance. That's a mouthful, but it just means the great arteries are connected to the wrong ventricles. Now here's a super important point. The atrioventricular connections, the hookups between the atria and the ventricles, are usually totally normal. The right atrium feeds the right ventricle, and the left atrium feeds the left ventricle. No, the problem is one step downstream. The aorta, which is supposed to get oxygenated blood from the left ventricle, is instead coming off the right. And the pulmonary artery is getting oxygen-rich blood from the left ventricle, which is just wrong.
And this slide, right here, shows you exactly why that's a 5-alarm fire. Normally, your circulation works in series. Blue blood comes into the right ventricle, gets shot to the lungs, comes back red, goes to the left ventricle, and out to the body. It's one big, beautiful loop. But in DTGA, you have two completely isolated loops running in parallel. The blue blood from the body goes to the right ventricle and gets pumped right back out to the body, still blue. Meanwhile, the red, oxygenated blood from the lungs goes to the left ventricle and gets pumped right back to the lungs. You see the problem? The body is starved of oxygen, while the lungs are just pointlessly re-oxygenating already red blood. Without some kind of connection, this just isn't compatible with life.
So this brings us to the million-dollar question, right? If these circuits are totally separate, how do these babies survive even for a second after birth? And the answer is one word: mixing. Everything, and I mean everything, depends on how much blood can mix between these two circuits. The baby's survival literally hinges on finding or creating holes, shunts, between these two parallel highways. The amount of blood that crosses over is what we call effective blood flow, and it's the only thing keeping the patient alive.
So, when you look at the patient's oxygen saturation, it really boils down to these key factors. First and foremost, the amount of mixing, which depends entirely on the anatomic shunts they have. We're talking about an ASD, a VSD, or a PDA. And size matters here, a lot. One big, non-restrictive opening is way better than a few tiny ones. Of course, you also need enough blood actually going to the lungs to get oxygenated in the first place. And finally, and this is where we as anesthesiologists really come into play, it's about the balance of vascular resistance. We need pulmonary resistance, the PVR, to be lower than systemic resistance, the SVR. That pressure difference is what encourages blood to flow the right way to allow for mixing. Anything that jacks up the PVR is going to make things worse, which is why our ventilator management and anesthetic choices are so incredibly crucial.
Okay, so we've nailed down the core physiology. Now let's switch gears and talk about how these babies actually show up at the door and how we classify what we're dealing with. Because it turns out, DTGA isn't a one-size-fits-all diagnosis. Any other little heart defects that come along for the ride can totally change the clinical picture and our entire plan.
We can really break DTGA down into these main groups. The most common one you'll see is DTGA with an intact ventricular septum, or IVS. This is your classic blue baby. They have terrible mixing, maybe just a tiny PDA, so they become profoundly cyanotic, like right away. Now, contrast that with a baby who has DTGA and a big VSD. Their problem isn't being blue. They have great mixing. Their problem is that they're getting absolutely flooded with pulmonary blood flow, so they crash from congestive heart failure. Then you have the tricky combination of a VSD plus left ventricular outflow tract obstruction, or LVOT.
That obstruction can actually protect them from heart failure by limiting blood flow to the lungs, but it also means less mixing, so they're back to being cyanotic. It's a real mixed bag. So how do we know for sure what we're dealing with? Echocardiography. It is the absolute gold standard. Now, one key thing echo helps us with is telling DTGA apart from its cousin, LTGA. Both have the TGA part, meaning the great arteries are switched. But in DTGA, remember the AV connections are normal. In LTGA, you have this double discordance, where the ventricles are switched too. It's a congenitally corrected physiology, which is a whole different ballgame. On the echo for DTGA, you're looking for that classic sign of the aorta sitting anterior and to the right of the pulmonary artery. You might hear about the egg on a string sign on a chest x-ray, and that's cute, but echo gives us the definitive answer.
Now, before we move on, there is one very specific, very scary clinical sign we have to talk about: reverse differential cyanosis. You know, we're used to seeing lower sats in the legs, but here it's flipped. The saturation in the right arm is lower than in the legs. When you see this, alarm bells should be going off in your head. It's a huge red flag that tells you the atrial septum is incredibly restrictive. The left atrial pressure is skyrocketing, which drives up the pulmonary artery pressure so high that it exceeds systemic pressure. What happens then? The oxygenated blood in the PA shunts right to left across the PDA and down into the aorta, which makes the legs pinker than the arm. Seeing this means you need to do a balloon atrial septostomy, like yesterday.
Okay, so the diagnosis is confirmed. The clock is officially ticking. Our entire mission now is to stabilize this tiny, fragile patient and get them in the best possible shape for the definitive surgical repair. This is a super delicate dance of meds and procedures, and for us in anesthesia, our goals are crystal clear. Get that oxygenation up, keep the cardiac output stable, and fight off that metabolic acidosis.
So what's the playbook? It's a pretty standardized protocol. Step 1, almost without fail, is to start a prostaglandin E1 infusion. PGE1. That's our magic potion to keep the ductus arteriosus open, which gives us a crucial spot for mixing. But often that's not enough, especially if the hole between the atria is tiny. So, step 2, we get the echo probe on and look at that atrial septum. If the baby is still super blue despite the PGE1, it's on to step 3, an emergency balloon atrial septostomy, or BAYAS. This is a lifesaver. We go in, rip open the atrial septum, and create a big, beautiful ASD. The sats just shoot up. This is often done at the bedside with us providing the anesthetic, and it can dramatically turn things around.
All right, our little patient is stabilized. Now we can turn our focus to the main event, the surgical fix. And honestly, the evolution of these surgeries is one of the coolest stories in medicine. We went from these clever but imperfect physiological workarounds to a full-on anatomical restoration. So let's look at the big three. Way back when, we had the atrial switch, the mustard or stenting procedures. They were genius for their time. They used a baffle inside the atria to reroute the blood. But they left the right ventricle as the systemic pump, and that poor RV just wasn't built for that kind of pressure long-term. They ran into all sorts of problems down the line. Then you have the Rastelli procedure. This is a great anatomical fix for a very specific subset of patients, those with a VSD and severe LVOTO. But for the vast majority of kids with DTGA today, the undisputed champion, the gold standard, is the Arterial Switch Operation, the ASO. It's a true anatomical correction. It puts everything back where it's supposed to be and lets the mighty left ventricle do its job as the systemic pump.
The ASO is an elegant, beautiful surgery, but it has a huge technical challenge, an Achilles heel, really. And it all comes down to one thing: the coronary arteries. The success or failure of an ASO hinges almost entirely on how those tiny little coronaries are handled.
You see, in DTGA, the coronary anatomy is just weird from the get-go. They come off the aorta in an unusual position. And while most are kind of typical, about a third of these babies have funky variations, like a single coronary, or even trickier, a coronary that runs inside the wall of the aorta itself, an intramural course. Those variations are a huge risk factor. The surgeon has to move these tiny arteries from the old aorta to the new one without twisting, stretching, or kinking them. It is the most delicate, high-stakes part of the whole operation. In fact, if something goes wrong early on after an ASO, it's almost always because of a problem with that coronary transfer.
This picture does a great job of showing you the magic. In panel A, you can see the surgeon has transected, or cut, the aorta and the pulmonary artery. Then they carefully carve out the coronary arteries with the little button of aortic tissue around them. Now look at panel B. This is the moment of truth. They've switched the great arteries. The old pulmonary artery is now connected to the left ventricle, becoming the neo-aorta, and those little coronary buttons are being meticulously sewn into their new home. This is all happening on bypass, often with the baby cooled way down, to give the surgeon a perfect, still field to work in. It's truly an anatomical masterpiece.
A successful ASO is a massive win, but our work is far from over. As we all know, the post-op period is its own battle. It's a time for extreme vigilance because these patients can throw us some unique and scary curveballs, especially in those first few hours after coming off bypass.
The number one thing we're all terrified of is myocardial ischemia. Like we said, one tiny kink in that reimplanted coronary can spell disaster. So, for us, any post-op hypotension, any new EKG change, any funky arrhythmia, you have to assume it's ischemia until proven otherwise. We are glued to the monitor, watching for ST changes and checking troponins and echo for any signs of ventricular dysfunction. Now down the road, the most common thing we see is supravalvular pulmonary stenosis, a narrowing where they sewed the new pulmonary artery. And long-term, we have to keep an eye on that neo-aortic root to make sure it doesn't dilate. So even with fantastic survival rates, these kids are patients for life.
All right, we've covered a ton of theory. To really pull all these pieces together, let's walk through a typical case. This will show how everything from diagnosis to stabilization to the final surgery fits together to give us a great outcome.
So picture this. A beautiful, full-term baby is born, looks great for a minute, and then starts getting dusky. The pulse ox reads 65%, an urgent echo is done, and boom, DTGA with an intact septum. We immediately start the PGE1, but the SOTs barely budge. Ding, ding, ding. That tells us the atrial communication is way too small. So the cardiology team rushes in for an emergency bedside BAS. As soon as that balloon rips open the septum, the SATs jump into the high 80s. Beautiful. The baby is stabilized. On day of life 5, they go for their ASO. The surgery is a success, the post-op course is nice and boring, and by day 12, the breathing tube is out. By day 21, the baby's heading home with their parents with a bright future ahead.
This case and this quote right here really just says it all. It's amazing to think that a condition that used to be uniformly fatal has been transformed into something we can fix and fix well. It's a testament to a deep understanding of the physiology, lightning-fast diagnosis, and incredible surgical skill.
And that brings us to the future. We've gotten so good at the plumbing, at repairing the heart itself. So what's the next great challenge? It's shifting from just survival to optimizing the quality of that survival. The next frontier is all about protecting the brain and improving neurodevelopmental outcomes for these kids who go through so much. How can we as a team better protect their brains through the hypoxemia, the bypass, the whole journey? That's the question that will drive the next wave of innovation in our field. Thank you so much for your time.